5 or something, and you start, okay? Well, we'll go now. Whatever you want.
¿Estamos?
Yes.
Okay. Buenas tardes a todos. Muchas gracias por unirse a esta nueva reunión. Hoy día voy a moderar con el doctor Juan Pablo Araf, quien es hepatólogo conocido.
Leila,
de la
sorry. Just a minute. People are entering because they weren't here yet. You should start again. Just a minute, because we have just one people in the audience soon.
Okay.
They're entering. Sorry.
¿Ahora?
Yeah. Okay. They're entering. You can start. They're just entering.
Hola, buenas tardes. Hoy día tenemos una muy interesante charla. Vamos a ver un update en hepatitis B. Me acompaña como moderador el doctor Juan Pablo Araf, hepatólogo de la Pontificia Universidad Católica de Chile. Adelante, Juan Pablo.
Muchas gracias a Leila, la doctora Leila Rosal, hepatóloga de Clínica Las Condes, y hoy día tenemos un invitado excepcional. Nos acompaña hoy día el doctor Benyam Adisi. El doctor Adisi es profesor asistente de la Universidad de Geisinger en Pensilvania. Él ha participado activamente de muchas investigaciones, sobre todo relacionadas a diferentes etnias y la hepatitis B, y también biomarcadores. Ustedes podrán recordar el score de Galat. El doctor Adisi estuvo participando y fue el primer autor de ese estudio. Así que es un honor para nosotros poder tenerlo hoy día, para que nos va a presentar este update de hepatitis B y que después podamos ir respondiendo las preguntas. Recuerden que en el borde inferior de la pantalla hay un botón que dice Q&A o Q&A, que es para hacer las preguntas, así que las pueden ir escribiendo ahí durante la presentación y las responderemos al final de la presentación. Agradecemos a la Asociación Chilena de Hepatología y a la Sociedad Chilena de Gastroenterología por la organización y permitirnos hacer este webinar. Adelante, doctora Adisi. Go ahead, Benjamin. You can share your screen.
All right. Good evening, everyone. I thank you all for the invitation for me to say a few things about hepatitis B. I know I am amongst world experts in this topic, but I just wanted to share some of the things that I know that's part of our practice here in Pennsylvania and the US. And I will say a few things that are very basic, because I understand there are some trainees watching this as well. But again, thank you for the invitation. I do not have any relevant disclosures to discuss. The overview of my talk will be to talk a little bit about the burden of hepatitis B infection in the world, and also focusing on what the World Health Organization has adopted as part of the global health sector strategy to eliminate hepatitis B by 2030, and say a few things about that initiative and our current screening guidelines and preventive measures that are being taken, and also go over indications for treatment and the different treatment options that are available for us currently, and future directions in the field. So hepatitis B, as you all know, is a partially double-stranded DNA enveloped virus. There are different genotypes from A to I with varying distribution globally. In the United States, genotypes A, B, C, and D tend to be more common. The prevalence in the world is quite high. I know these days we can only think of one virus, but this virus has been a big problem throughout. According to the most recent data from the 2019, the World Health Organization estimates 296 million people living with chronic hepatitis B and 1.5 million new infections happening every year. And almost a billion people, almost a million people die from this virus, 820,000 that happened in 2019. And the prevalence is quite variable across the globe. Most of the infections happen in sub-Saharan Africa and Southeast Asia and the Western Pacific region. The prevalence can be as high as more than 8% of the population having positive serological markers indicating active infection. And there are other regions of the world, including the United States and Chile, with incidence rates less than 2%.
Can you please enter full screen for your PPT? There you go. Thank you.
All right. All right. So as I mentioned, the incidence is quite variable across the world. But even in countries with low incidence rates, the incidence rate is rising. For example, in the United States, there are reports clearly show that the incidence has been rising in recent years across the different age groups. And this tends to be related to globalization and movement of population, because most of patients that we see with chronic hepatitis B were born outside of the United States, and they come from areas of the world where this infection is endemic. That said, acute infection is still rising, as this chart shows, across age groups. And this tends to be attributed to resurgence of epidemic of injection drug use, particularly in parts of the country, the non-urban areas where there's significant rise in opiate use. We do see increase in incidence of new hepatitis B infections. And of course, this trend is not just in the US, but in many different countries too. And this is only, we know this in patients that are being screened. As of 2019, majority of the population in the world with chronic hepatitis B are not diagnosed, and the WHO estimated only 10.5% of the total estimate, which is about 30.4 million people, are aware of their infections. And among those, only 22% are on treatment or are getting the proper management, which means that because of the increasing incidence and because most people are not diagnosed, wide screening programs are recommended. In the US, the AASLD recommends screening, a more targeted screening of different groups of the population whose incidence is estimated to be high. And I put this table that they have in their guideline to indicate that it's a large number of groups that are considered to be at increased risk and require screening. And globally, the World Health Organization recognizes this, that this is severe or high burden to healthcare. And at their annual World Health Assembly in 2016, they adopted this global health sector strategy, which set a goal to eliminate viral hepatitis as a public health threat by the year 2030. And this is defined as reducing new infections by 90% from the baseline in 2015, and also reducing mortality rate by 65%. And these were very achievable goals, and they had focused on these 5 areas where a lot of strategic information interventions, equity and financing and innovations are going to be focused on. And this is improving vaccination efforts and improving prevention mother-to-child transmission, and improving injection and blood safety, harm reduction, and test and treatment of viral hepatitis. Unfortunately, as of now, only 12 countries are on track to reach this goal, most of them being in Western Europe. The US and Chile and many other countries are not among these countries. And us as hepatologists and gastroenterologists, we may not be directly involved in public health strategies, but there are areas of, I picked 3 of these that we can have direct impact on, including vaccination efforts and prevention of mother-to-child transmission, and also improving testing and treatment strategies. So starting with vaccination, as you all know, hepatitis B vaccination is quite effective, 98 to 100% effective in preventing infections if the patient has adequate amount of anti-hepatitis B surface antibody. And there are different formulations of vaccination that are currently available that we use here in the US. The newest one is this HBeAg that uses a new product that helps induce immunogenicity. It's only 2 doses. The others are 3 doses, and they all have different doses and different schedules, but they're all quite effective. And with serology, titer level greater than 10 is considered to be protective. This new one that I mentioned tends to have improved immunogenicity. According to one study, that 90 to 100% patients achieve this goal, compared to the 70 to 90% with the previously used versions. Even in patients who do not have this titer, the protective effect is still there, and the protective effect lasts quite a while. This one study that was done in Alaska looked at patients who were vaccinated decades ago, that had completed their vaccination series and more than 30 years ago. They looked at their hepatitis B surface antibody titers, and more than half of them still had protective levels. And among those who did not have protected levels, they responded robustly when they were given one more dose, and 88% of them had this response, indicating that they may not have the antibody levels, but they may have the cellular immunity and good memory of the protection, which means that most patients, even if they did not achieve the protective titers, continue to have protection from this vaccination. The other area is prevention of mother-to-child transmission. This is very important because up to 90% of patients who were infected before age 5 end up developing chronic infection. And many of it is due to vertical transmission from mother to child during birth, but a large percentage of it is horizontal transmission, where children are infected in early childhood from the other family members. This is particularly important in endemic regions of the world. Which takes me back to vaccination, and timely vaccination of infants does help protect a large percentage of the population that end up developing chronic infection. Most countries are doing quite well in achieving this. according to the last report, 87% of infants do receive 3 doses by their first birthday. The goal is 90%, and it was 82% at baseline in 2015. So good progress is being made, but only 46% were administered the critical birth dose. And as I mentioned, that early childhood period is quite important, and the goal is to give at least the first dose to 90% of infants during the first day of birth, but it's only 46% right now. This is improved from 38% in 2015, but there's still ways to go. As part of the prevention to mother-to-child transmission, all pregnant women need to be screened, and simple hepatitis B surface antigen testing is adequate to identify women with active infection. And those pregnant women whose hepatitis B DNA level is more than 200,000, antiviral therapy is recommended during their 3rd trimester. And this helps reduce perinatal transmission, but also up to 25% of pregnant women with hepatitis B can have flares during the later half of their pregnancy. And antiviral therapy does help prevent this as well. The additional measure that is recommended is use of hepatitis B immunoglobulins to be administered to infants within 12 hours after birth. This is, again, particularly important for those with high viral load and those with E antigen positive serology. The next step is the consideration of different types of treatments that are available. Currently, the approved treatments are interferon, which has been around for a long time, and also nucleoside or nucleotide analogs, including lamivudine, adefovir, entecavir, tabivudine, and tenofovir formulations. Entecavir and tenofovir are what are most commonly used because of their high efficiency in reducing viral load and very low rate of resistance. There are 2 formulations, the second one, TAF, being the most recently approved one, and it has less adverse effects on kidneys and bone health, which makes it the preferred agent. And with treatment, the goals of treatment are to induce virological response, and this is by reducing hepatitis B DNA level to undetectable levels, and also induce serological marker effects by causing hepatitis B antigen loss and seroconversion, and ideally to also induce hepatitis B surface antigen loss, which I'll go a little more into. The other goal is to have biochemical response by normalizing liver chemistry, and additionally histological response is also the goal. Although we don't do routine biopsies in patients while on treatment, we would like to reduce inflammation and fibrosis in their liver. And ultimately, the clinical response we want is to reduce risk of cirrhosis and complications from cirrhosis, decompensation, development of cancer, and death. The course of hepatitis B infection and our management heavily relies on where in the phase of their chronic hepatitis B the patient is. This is because hepatitis B infection is a quite dynamic infection, and patients can transition from one phase to another. And this depends on if this is an acute infection versus chronic infection, and by definition, having more than 6 months of duration of positive test indicates that this is chronic. Hepatitis B DNA levels can be variable, it can be undetectable to billions. international units per milliliter, and presence of different antigens, particularly hepatitis B antigen, defines these phases. And of course, liver chemistry and degree of inflammation, that's checked with the blood test and also histology. So this figure that I really like and I use quite often to guide my clinical practice and also teaching shows the different phases that patients go through with chronic hepatitis B. First one being the immune tolerant phase, which most young patients who are infected at young age tend to be in. They have quite high hepatitis B DNA levels, but not as much inflammation as measured by their liver enzyme levels. And even if we do liver biopsy, we wouldn't see as much inflammation. And this is the immune tolerant phase. And with time, patients tend to transition to the immune reactive phase, where there is significant inflammation measured by liver enzyme levels. And hepatitis B antigen tends to be positive in this phase, similar to immune tolerant phase, as you see here. But their hepatitis E antibody level is not there. And they may switch spontaneously or with treatment to this other phase where they're either inactive carriers or they're in this immune control state where their E antibody level is positive and their DNA level is low. And again, they may switch to another phase where they escape this immune control phase, and this may be loss of response to their treatment or again spontaneously. And ultimately, we would like to get them into this essentially cure state or functional cure state where their surface antibody level is negative. And patients again may switch between one phase to another, which is why hepatitis B is considered a dynamic infection. And we tend to focus our treatment to these two phases where there is inflammation and progression of fibrosis. And we do not usually treat all phases of chronic infection because of potential side effects or adverse effects for treatment, and there's a cost associated with it too. And because most patients require very long-term treatment, we tend to be more selective. But we still depend our treatment to which phase they are in. Currently, the AASLD gives us guidelines in terms of who to treat and how we choose our management. Going back to the different phases, if we focus on those that are hepatitis E antigen positive, which is the second phase here, we look at liver chemistry markers to help us if they are having active inflammation. If not, they're usually in the immune tolerant phase. And even if they have very high DNA levels, treatment is not indicated. But when there is inflammation defined by rise in ALT more than 2 times upper limit of normal, particularly associated with increased DNA levels more than 20,000, treatment is indicated. And if the DNA level is not that high, but more than 2,000, if we have other signs of active inflammation, like biopsy results, we may still consider treatment. And for those who are E antigen negative, we still like to know where they are in terms of inflammation. We if they do not have high DNA levels, that may indicate that they may be either an inactive carrier, which means that there's not much inflammation and the treatment may not give them as much benefit. But if they have increased DNA levels, they may be in this immune escape state where treatment is indicated. So again, this is to kind of summarize that use of serology markers, DNA levels, and inflammation markers guide us with our decision of who to treat. The current treatments that we have are quite effective in achieving our clinical goals, but we do have limitations. This covalently circular DNA that is in the cytoplasm is, and also the integrated DNA from the virus are not affected by our nucleoside antagonist treatments. So that's one limitation of our current treatments. And our goal of ultimately achieving hepatitis B surface antigen loss is still low. And as I mentioned already, long-term duration is required when we use our current treatments. And even in patients who are on treatment adequately, there is still risk of hepatocellular carcinoma. And so these are our current limitations at the moment. And according to this report from a group in Michigan, the current rate of hepatitis B surface antigen loss is quite low. In patients who are Hep B antigen positive, even after 7 to 10 years of effective antiviral therapy, we only achieve 2.5% with entecavir and 4.9% with tenofovir, which are quite low. Even with use of interferon, pegylated interferon alpha, the rate is 11%, which is better, but it's still quite low, especially when you compare it to what we're able to achieve for hepatitis C treatments. And the rate is similar, if not worse, in patients who are E antigen negative. We have some markers to guide us where patients are in terms of their hepatitis B infection, and quantitative hepatitis B surface antigen, instead of just positive negative, having some quantitative value can be helpful. But this has low specificity since it does not really tell us if the surface antigen is coming from or transcribed from integrated DNA or the covalently circular DNA. And the genotypes may have variable results as well. But it is one tool that we have. So as I mentioned, most patients require very long-term treatment, and that's not always ideal. And patients ask us when they can stop taking their medications. And the AASLD gives us some recommendations about that. For those with E antigen positive and no cirrhosis, we can consider stopping treatment if they achieve seroconversion and have undetectable hepatitis B DNA for at least 12 months. And for those with E antigen negative while on treatment, and again, no cirrhosis, we can't use seroconversion as a marker, and we may have to wait until they lose their surface antigen for consideration of stopping treatment. At least that's what the current guidelines are suggesting. And if there is cirrhosis, stopping treatment is not recommended because of risk of decompensation. There are different trials being performed to see what we can do to induce loss of hepatitis B surface antigen. This study, the Stop-NUC trial from Europe, showed that withdrawal of treatment may have some benefit in increasing cure or functional cure or loss of surface antigen. They had 158 patients, all of them E antigen negative, which tend to be the ones that we have difficulty in deciding stopping treatment. And all of them have been on long-term treatment with very low DNA levels for at least 4 years and normal liver chemistry. They randomized them into 2 arms, where one arm continued treatment, where the other one discontinued treatment. And the ones that discontinued treatment, 10% of them, compared to 0%, were able to lose their surface antigen, which is encouraging. And among those who had relapse, 68% did not require a resumption of DNA because they didn't have any markers for inflammation. And they saw some markers that could indicate this. Those with low surface antigen quantitatively prior to discontinuation tended to have achieved this. So that was one marker and another benefit of this biomarker. And so in the future, our goal is to have higher rate of surface antigen loss, and ideally with a finite course of treatment. And this will require different strategies and targeting different points in the life cycle of the virus. And Dr. Locke from Michigan had, in her review in 2017, had outlined different potential targets that could be used for future drug development. For example, if we were to use one of these steps where we target the translation by use of RNA interference, there was one trial, a small trial, that showed sustained suspension of suppression of hepatitis B surface antigen levels after 3 doses of this medication, which is an RNA interference drug. And this abstract had shown that just with 3 monthly doses, many patients had significant drop in their DNA levels, more than 1 logarithmic scale, and 40% had sustained suppression even after 9 months after they received their doses, which is encouraging. And it was a small study, and more randomized trials need to be done on it, but that was encouraging. And another target they used was targeting capsid assembly and use of some capsid assembly modulators like this drug, particularly in combination with entecavir, did show promising results. This trial had 25 patients, again, small trial, but treatment naive patients, when they had this drug added to entecavir compared to placebo, did have faster decline in their DNA levels just in a matter of weeks, and also more sustained response. There were also trials that used combination of different targets. Another small study had used the siRNA capsid assembly modulators and nucleoside analogs that also showed promising results. And they have different dosing schedules here, but the big picture is that if we target different aspects of the hepatitis B life cycle, we may be able to achieve even better results. Another target is to modulate immune response to hepatitis B. And again, what Dr. Locke had shown potential targets that one can use with therapeutic vaccinations and recovery of exhausted adaptive immunity, which patients with chronic Hep B tend to have, and stimulation of innate immunity are other potential targets. So to summarize my talk, hepatitis B continues to be a major health care burden globally, particularly in certain parts of the world. The incidence tends to go up even in those areas with low incidence rates. And we need to have aggressive measures to be able to achieve World Health Organization's goals to eliminate viral hepatitis from being a major health threat. And to reduce prevalence, we will need to reduce new infections by vaccinations and reducing mother-to-child transmission, which we have clear guidelines to how we are able to do that. There are screening guidelines laid out for at-risk populations, and effective treatments are available to achieve clinical goals, but even better treatments are in our future, which are able to hopefully achieve a functional cure with a limited course of treatment. All right, and thank you for your attention, and I can take questions.
Bueno, muchas gracias, doctora Dizzy, por la excelente presentación. A continuación, algunas preguntas del público. Una de las preguntas es, ¿cuándo elegiría un antiviral versus otro? Es decir, entecavir versus tenofovir. Y aún más, ¿tendría algún rol el PEG interferón actualmente? ¿En qué pacientes lo utilizaría?
Not sure if you started your interpretation, Benjamin, so you can hear in English. So in the bottom left of the screen, bottom right, sorry. There, okay.
I can hear you, yes.
Okay.
Ahora sí, Leila.
No, I have not.
¿Repetimos la pregunta?
Sí.
Ok. ¿Cuándo elegiría un antiviral versus otro? Es decir, ¿cuánto entecavir versus tenofovir? ¿Y tendría actualmente algún rol el PEG interferón? ¿En qué pacientes lo utilizaría?
Thank you. That's a good question. They're both very effective medications, and they have almost equivalent response in reducing hepatitis B DNA levels. For example, for pregnant women, we cannot use entecavir because of potential adverse effects to the baby, so tenofovir is preferred. And tenofovir levels in the body may be affected by if the patient takes it before eating and after eating. And for me, for example, college students or residents, I tend to use entecavir because it doesn't matter as much what time they eat. Oftentimes, at least in the US, the insurance coverage may be different, and we have to see which drug will be covered by their insurance providers. So they unfortunately have a lot of input in terms of which medication we use. Other adverse effects that we watch for kidney function, we have to be more selective because of potential nephrotoxicity of tenofovir, especially in patients with very low GFRs. So those are some of the factors that I look at when we choose which drug to use. But oftentimes, either one work well. So.
Tenemos una segunda pregunta que hace el doctor Juan Pablo Roblero. El doctor Roblero pregunta, ¿qué esquema de vacunación utilizan ustedes en pacientes con cirrosis? Y si es que tiene alguna opinión de qué esquema le parece que sería más efectivo.
Yes, the response rate for patients with cirrhosis and other immunosuppressed states tends to be low. I typically just use what the CDC recommends, which is 3 doses of the widely available formulation. I also vaccinate them for hepatitis A. So the formulation that has both of them together, Twinrix, is one that I often use. Routinely, I screen if they have surface antibody or not before vaccination to see if it is needed in the first place. But I do that. The newer vaccination, which is HBsAg B, tends to have, it's more convenient because it's 2 doses and its immunogenicity is better. So I tend to use that as well. But it's not available everywhere and insurance doesn't always cover it. So again, that becomes a factor.
Y volviendo también al tema de la vacunación, ¿en qué pacientes que han sido vacunados y en qué momento medir anticuerpos antiantígenos de superficie? Y en la misma línea, ¿miden anticuerpos antiantígenos de superficie en pacientes posterior a una recuperación de hepatitis B aguda? Y si estos fueran negativos, ¿recomendaría la revacunación en los 2 escenarios, es decir, post-vacuna y post-hepatitis B aguda?
Yes, so those are good questions as well. So as I mentioned, the level is important, and that's usually how we can tell if the person is immune or not. After an acute infection, what we tend to do is to make sure they have not developed chronic infection. So after 6 months to a year, we tend to check surface antigen, but most patients that were infected as adults do not have that. As part of the screening, we do check surface antibody level, regardless of known history or not. And if they are not immune just based on that surface antibody level, regardless of what other markers are saying, I do tend to start vaccination series in them. I think those were all the questions.
El doctor, gracias doctora Dici. El doctor Jaime Poniachik nos pregunta, un paciente con cirrosis que pierde el antígeno de superficie con antiantígeno de superficie, ¿suspende la terapia?
I don't, because the current AASLD guidelines do not recommend to ever stopping that. I have not seen that happen. It would be nice to see, and it will be indicating that there's less risk of cancer and decompensation, but I tend to continue and never stop in cirrhosis.
Perfecto. Y algunas otras preguntas que también han surgido. ¿Rol de la biopsia actualmente versus usar elastografía? ¿Cuándo uno, cuándo otro?
Okay, so the role of biopsy can be 2 things. One is to assess if there is a degree of inflammation, even with normal liver chemistry. And this is to see if we need to start treatment or not, if there is inflammation. The other part is to assess degree of fibrosis. And as you know, imaging and the blood tests don't always tell us how much fibrosis there is. So when we need to know, we tend to get either an elastography or a biopsy. I tend to favor elastography just because it's readily available, it's less invasive, and it's fairly accurate. But when it's not clear, or when the data we're getting from elastography and other things is not very accurate, I tend to proceed with biopsy. Or if the values are sort of borderline, I tend to do that. Oftentimes, when I'm concerned about the patient's progression and their liver health, and I want to start treatment, but we don't have all the checklist to start treatment, I tend to do a biopsy as well to see if there is some degree of inflammation. So those are the situations that I would do biopsy, but I tend to favor elastography on most cases.
Otra pregunta que tenemos acá, un poco, ¿cuán cercano ve que tengamos un tratamiento curativo para el virus de la hepatitis B en el futuro? ¿Y cuál cree que será el mecanismo que se utilizará para aquello?
I hope it's in the near future. I know we used to say cure for hepatitis C is way in the future, but that happened sooner than most people thought. So I'm hoping the same will happen for hepatitis B. I don't know of many published studies that included large number of patients so far. So I don't think it will happen the next couple of years, but hopefully within the next decade or maybe a little more, we would start to see that. Most likely it will be combination treatment that targets different mechanisms of the viral life cycle, which means that we may have to continue to use the current medications and add one or two more to that.
Y otra pregunta que surge también en ocasiones en la práctica clínica, en aquellos pacientes que van a ser sometidos a una inmunosupresión importante, una quimioterapia o dosis alta de corticoides, y que tienen anticore positivo pero antígeno de superficie negativo. ¿Recomendaría tratamiento o seguimiento con transaminasas o con carga viral? Tratamiento profiláctico.
Yes, so that's a very important question, which we see often in clinical settings. I didn't go too much into that in my talk, but the way the current guidelines suggest is that we look at the immunosuppression, the type of immunosuppression, and what the risk is of relapse with that immunosuppression. Most of the time, if the immunosuppression is not severely B cell depleting, or if it's not certain types of chemotherapy that induce reduced B cell immunity, then it is okay to monitor without initiation of therapy. But that also depends on how closely the patient is being monitored, how practical is it, how reliable the patient is, and getting frequent tests. If those are not met, I tend to favor starting immunosuppression and prophylaxis with antiviral therapy. And I will often work with either the oncologist or rheumatologist or whoever is managing the immunosuppression to decide together as a team to see what we need to do.
Otra pregunta que también vemos no infrecuentemente es un paciente con una hepatitis aguda grave por virus B con un INR mayor a 1.5. ¿Se trata en la hepatitis B o existe temor respecto a la toxicidad en un paciente con una hepatitis aguda grave?
Yes, so fortunately it doesn't happen that often, but when a patient is that sick, we tend to be more aggressive, and oftentimes they're in the hospital being closely monitored. So I tend to start treatment. Some of my colleagues who are a little more mature and experienced tend to favor monitoring without having to react and start treatment. But oftentimes when a patient is that sick, I tend to be more aggressive with my treatment, especially if they're being monitored for any toxicity they may have.
Y un par de preguntas en cuanto a hepatocarcinoma. En un paciente que tiene antígeno de superficie positivo con transmenasas normales, pero antecedente familiar de hepatocarcinoma, ¿lo trataría igual o solamente por el antecedente familiar?
Well, I still use the other guidelines, the other indications, and I don't add family history of hepatocarcinoma to decide to treat or not, because I feel like if they do not have significant inflammation, the risk of cancer probably would be low enough, even with the family history. That said, if there's any soft indication, if they're say over 40, or if they're male, or any other variable that increases the risk of cancer, in addition to their family history, then I tend to start treatment with the hope of reducing their risk of cancer. Same goes with who needs to be on a screening program or surveillance program for hepatocellular carcinoma, particularly with family history.
Otra pregunta respecto a screening. Hemos visto cómo en hepatitis C se ha ido ampliando la población que debería recibir screening. ¿Cuál es su opinión de quiénes deberían recibir screening? ¿Toda la población, los mayores de 18 o algún otro punto de corte o alguna población de riesgo?
Yes, so that is based on the modeling studies that were done to see what would be the cutoff for cost effectiveness when we enroll patients. For patients with chronic hepatitis B, if I remember the number right, if the risk is more than 0.5 per year for the person, then it would be cost effective to start surveillance. And currently it says that routinely in patients without cirrhosis, for example, who are of Asian origin, their risk may be high enough if they're over 40 for men and over 50 for women. And those of African descent, we tend to start surveillance program in those who are over age 20 or 25. But other populations without cirrhosis, their risk of HCC tends to be quite low, and it may not be worth the effort and cost to enroll them in a surveillance program. And this is based on the current methods that are being used for surveillance, which is imaging modalities and alpha-fetoprotein. Maybe in the future, if other modalities that cost less and less invasive come by, maybe the guidelines can change. But that's what we do currently.
Y volviendo al tratamiento, ¿algún rol del PEG interferón hoy en día? Por ejemplo, un paciente joven que quiera tratamiento finito, o de frente pasamos a los antivirales actuales.
Okay, yes.
¿Usaría PEG interferón en algún paciente hoy en día?
Okay. I have not used it yet, but it is a valid approved treatment, particularly in patients who are young, like you said, and we don't want to commit them for long-term treatment because the rate of functional cure tends to be higher when we use interferon-as, and I showed some of the data there. But because of the adverse effects that most patients can get with interferon, which requires many months treatment at least. But alternatively, the entecavir or tenofovir do not have that much adverse effects, even with long-term use. For that reason, I have not used PEG interferon, but there's clearly a role for it.
Muchas gracias. Tenemos una última pregunta del doctor Roblero. En su opinión, ¿cuáles son las poblaciones de riesgo que se benefician de buscar la infección por hepatitis B o de hacer screening de infección por hepatitis B?
Okay, the current guidelines suggest that if the rate is more than 2 or 3%, then we should consider screening. That includes those of East Asian or Sub-Saharan African origin, or who are immigrants, or those with other bloodborne infections like HIV or hepatitis C, and those who actively use drugs or that puts them at risk for hepatitis B infection, those with family members with known chronic hepatitis B infection. These are some of the groups that I would screen because their risk of infections tends to be high. But because the incidence is rising even in other groups, we should consider screening all of our patients, particularly if the test is not that invasive and false positivity rate or other unnecessary treatments that come with screening is very low. So I would suggest screening everyone, but the current guidelines are, at least the AASLE guidelines, are more targeted.
Bueno, muchísimas gracias, doctor, por su excelente presentación y muchas más gracias aún por la excelente ronda de preguntas. Creo que hemos aprendido mucho y hemos podido aclarar muchas dudas. Agradecemos también al Laboratorio Gador por habernos apoyado en estas reuniones de hepatitis. Y creo que con esto podemos dar por finalizada esta excelente presentación. Gracias a todos también los que se han conectado y han participado de esta reunión.
Muchas gracias a todos. Que tengan buenas noches.
Buenas noches.
Good night. Thank you, everyone.